Assalamu alaikum, everyone. Hope you all are doing well and your prep for the exam is going well too. I'm Hafsah Khalifey, a third-year medical student, and today I'll be giving the pharmacology practice question session for POD, inshallah. Now, this session should help you revise the key concepts and hopefully it's beneficial. To get things started, I'll be showing you a question and I'll read it out, and then you guys can answer it in the chat, or if you want, you can unmute yourselves. And then we'll discuss each question with a short or quick explanation. So let's get started. Let's begin with something simple. So the first question, which scenario is most likely to increase the risk of adverse effects from a drug highly bound to plasma proteins? And the options are an increase in plasma albumin levels, co-administration with another drug that has higher affinity for the same protein, increasing the dose of the drug, or administering the drug in a delayed release formulation. Okay, so the answer is B, which is co-administration with another drug that has higher affinity for the same protein. Now, why is the answer B?
I guess because then it will start competing for binding to the same protein, right?
Yes, exactly. So basically, when a drug is bound to plasma proteins, it's inactive. So the risk of toxicity is low. So now, if we administer another drug which has a higher affinity for the same protein, so the original drug will be displaced, and that will increase the free drug concentration, and that will lead to the adverse effects or toxicity. Now let's move on to the next question, which is which phase of drug metabolism involves conjugation with an endogenous substrate? Phase 1, phase 2, glomerular filtration, or tubular secretion?
Phase 2.
Yes, right. So the answer is phase 2. And that's because in phase 1, what happens is lipophilic drugs are converted into more polar metabolites through oxidation, reduction, or hydrolysis. And then the phase 2 consists of conjugation reactions where drugs or the metabolites from phase 1 are linked with endogenous substances so that they can form more water-soluble compounds for easier excretion. Okay. Now we can move on to the next question. A 45-year-old woman with a history of renal impairment is prescribed nafcillin for a bacterial infection. Why does nafcillin not require dose adjustment in this patient? Options are, it is primarily metabolized by the liver and excreted in bile. It has very short half-life, making dose adjustment unnecessary. C, it is narrow-spectrum antibiotic that does not affect renal function. D, it undergoes extensive first-pass metabolism, reducing its effect on kidneys.
A.
Yeah, that's right. So, and someone answered in chat too. A is the correct answer. It is primarily metabolized by the liver and excreted in bile.
Wait, is this also the same for oxacillin?
Yes, it is the same for oxacillin. So basically, remember that from beta-lactams, there are two drugs, nafcillin and oxacillin, which are excreted via bile, and the others are excreted via kidney. So whenever a patient presents with a renal dysfunction or renal impairment, we go with nafcillin or oxacillin. Now, let's move on to the next question. A 45-year-old patient is admitted to the hospital with a severe respiratory tract infection. The culture results indicate an infection caused by aerobic gram-negative bacteria. The physician decides to start the patient on aztreonam, a monobactam antibiotic. What is the mechanism of action of aztreonam in treating this patient? A, inhibits bacterial protein synthesis by binding to 30S ribosomal subunit. B, inhibits the last step of bacterial cell wall synthesis by binding to PBPs. C, inhibits DNA synthesis by targeting DNA gyrase. D, disrupts the bacterial cell membrane by binding to lipopolysaccharides.
B.
Is it B?
Yes, you're right. It's B. And so basically, monobactams, their MOA or mechanism of action is that they inhibit the transpeptidase enzyme, which is involved in the cross-linking of peptidoglycan strands in the bacterial cell wall. So now this inhibition of the enzyme prevents the formation of a stable cell wall, leading to bacterial cell lysis. Hope that's clear. Let's move on to the next question. A 45-year-old female with a known allergy to penicillin is being treated for a serious skin infection caused by MRSA. The physician is considering using vancomycin. Which of the following adverse effects is most likely associated with vancomycin therapy? A, hepatotoxicity, B, red man syndrome, C, thrombocytopenia, D, peripheral neuropathy.
Is it a B?
Yes, right, it's B. Now, here's an easy way to remember the adverse effects for vancomycin. VANHO, so basically V stands for venous thrombosis, A for allergy, and allergy is the red man syndrome, which is because of histamine release and cytokine release. And that leads to presentation like flushing, rashes, hypotension. And N stands for nephrotoxicity, H stands for hypersensitivity, and O stands for ototoxicity. Now let's move on to the next question. A physician is treating a patient with severe urinary tract infection using tropramycin. Which of the following statements regarding the pharmacokinetics of aminoglycosides is true? A, they are well absorbed when administered orally. B, they can easily cross the blood-brain barrier. C, they require oxygen for uptake into bacterial cells. D, they are metabolized extensively in the liver.
D.
What did you say?
D.
Isn't it? I don't know, maybe C?
Okay, yeah. So the correct answer is C. They require oxygen for the uptake into bacterial cells.
They're aerobic. They work on aerobic bacteria.
Exactly. So you need to remember that aminoglycosides, their spectrum is mainly on aerobic gram-negative bacteria. And oxygen is one of the requirements for them to work. So they would be ineffective against anaerobic bacteria. As for other options, they are poorly absorbed from the gut, so they need to be administered intramuscularly or through IV. Hope that's clear. So question number 7, a physician prescribes chloramphenicol to a patient with typhoid fever. Which of the following adverse effects should the physician monitor for? A, nausea and vomiting. B, aplastic anemia. C, rash. D, liver toxicity.
Is it a B?
B.
Aplastic anemia.
It's B.
Yes, it is B. You're right. Aplastic anemia. So one of the important adverse effects for chloramphenicol is it can cause aplastic anemia, which is unpredictable and it can be fatal. So if someone presents with this side effect, it's necessary that we stop the treatment. So it's very important to monitor patients on chloramphenicol for aplastic anemia, especially when you're giving long-term therapy. Any questions until now? Okay, so let's move on to the next question. A 60-year-old male patient is being treated with clindamycin for an anaerobic bacterial infection. What is the mechanism of action of clindamycin? A. Inhibits 30S ribosomal subunit. B. Inhibits 50S ribosomal peptidyl transferase. C. Blocking translocation at 50S ribosomal subunit. D. Disruption of bacterial DNA gyrase. Okay, so yes, everyone who answered C in the chat, you're right. It's blocking translocation at 50S ribosomal subunit. So basically, clindamycin belongs to lincosamides class, and they work by binding to the 50S ribosomal subunit. So they block the translocation. So protein synthesis is prevented in the bacteria. Now, an easy way to remember the mechanism of action for these drugs is by at 30, cell at 50. So at A stands for aminoglycosides, T for tetracycline. So they work at the 30th subunit. And C, in cell, so C stands for chloramphenicol, clindamycin, E stands for erythromycin, and L stands for linezolid. So, and all of these work at 50S ribosomal subunit. Now, let's move on to the next question. A patient presents with abdominal pain and has been taking tetracycline. What advice should the healthcare provider give regarding the timing of medication intake? A. Take it with calcium-rich food to enhance absorption. B. Take it immediately after meals for better tolerance. C. Avoid dairy products and antacids for at least 2 hours before and after taking the medication. D. It can be taken at any time without regards to the meals.
C.
Yes,
It's C.
you're right. So the answer is C, and it's very important to remember this. So basically, tetracyclines, whether they are tetracycline, doxycycline, minocycline, tigecycline, all of these, they need to be administered at least 2 hours before or after taking antacids. Why? Because antacids interrupt their absorption, and that would affect their action. Now, for the 10th question, a 60-year-old woman is being treated for pyogenic bacterial infection. She develops a severe skin rash and fever, Stevens-Johnson syndrome, shortly after starting medication. Which of the following drugs is most likely responsible for her symptoms? A. Sulfamethoxazole. B. Trimethoprim. C. Ciprofloxacin. D. Amoxicillin. So what's the answer? Okay, someone's saying C. Nope, C is not the answer.
X.
Stevens-Johnson is the keyword.
Is it B?
Okay, so the answer is A, sulfamethoxazole. Now, I know it's difficult to remember the adverse effects because there are many, but for sulfamethoxazole, specifically, remember Stevens-Johnson's as one of the important adverse effects. And it's easy to remember because S, Stevens-Johnson's, and S, sulfamethoxazole. Is that clear? Can we move on to the next question?
Yes.
Okay. So the next question is, a 30-year-old woman with a history of tendonitis is treated with a new antibiotic for a respiratory infection. She returns to the clinic complaining of severe pain in her Achilles tendon. Which antibiotic is most likely responsible for her symptoms? A. Gemifloxacin. B. Amoxicillin. C. Sulfamethoxazole. D. Trimethoprim. Okay, so yes, you're right. It's A. Gemifloxacin. Now, severe pain and rupture of tendons is very important, and it's linked to fluoroquinolones. So, because they can cause damage to the growing cartilage and increase the risk of tendon rupture. So, if in the question you see Achilles tendon or tendon rupture, directly your mind should go towards fluoroquinolones. And from the drugs which were mentioned here, the only relevant option was gemifloxacin. And also, because this is one of the adverse effects, it is contraindicated in patients who present with a history of tendon disorders. Now, let's move on to the next question. A patient suffering from osteoarthritis is prescribed an analgesic that selectively inhibits COX-2 without affecting COX-1. This drug is known to decrease pain and inflammation while minimizing gastrointestinal side effects. Which of the following drugs is the patient likely taking? A. Aspirin, B. Ibuprofen, C. Celecoxib, D. Naproxen. Okay, yes, you're right. So the answer is celecoxib. And it's an easy way or trick to remember is cele starts with CELE, which is very similar to selective. So celecoxib is the only selective COX-2 inhibitor. Now, let's move on to the next question. A 35-year-old man with a history of hypertension and asthma and nasal polyps is prescribed aspirin for pain relief. Which of the following conditions is a significant contraindication for aspirin in this patient? A. History of hypertension. B. Allergies to penicillin. C. Asthma with nasal polyps. D. Diabetes mellitus. Yes, it's C. Asthma with nasal polyps. So even though the patient had a history of hypertension and stuff, but what you should be focusing on as soon as you hear aspirin is asthma with nasal polyps. And remember, in such patients, aspirin should be avoided or it's contraindicated. Now, the next question. A physician is considering a medication for a newborn with a patent ductus arteriosus. Which of the following medications is used in the closure of PDA due to its ability to inhibit prostaglandin synthesis? Indomethacin, ibuprofen, paracetamol, diclofenac. Yes, you're right. It's indomethacin. So indomethacin it belongs to which class of drugs? Is it selective COX inhibitor or non-selective? Yes, it is non-selective. So basically, it's a non-selective COX inhibitor, and it is commonly used to promote the closure of patent ductus arteriosus in newborns by inhibiting prostaglandin synthesis. Next question, a 70-year-old patient with a history of benign prostatic hyperplasia presents with urinary retention. The physician decides to prescribe a medication that stimulates bladder contraction. Which of the following drugs would be most appropriate for this patient? A. Atropine, B. Bethanechol, C. Carbachol, D. Edrophonium. Okay, someone answered B, and yes, that's the correct answer. Bethanechol. Why? Because bethanechol is a direct acting cholinergic agonist, and that it specifically targets what kind of receptors? Muscarinic receptors, which stimulate bladder contraction. So it is very useful in treating urinary retention, especially in patients with BPH. So if you hear BPH, BB bethanechol. Whereas the other options like atropine, it's anticholinergic. So it would exacerbate urinary retention. We can't use it to treat it. Carbachol is it's less commonly used because it has very non-selective action. Edrophonium is a reversible acetylcholine esterase inhibitor, and it is usually used for the diagnosis of which disease? Edrophonium.
Myasthenia gravis.
Yes, exactly. So it's used for myasthenia gravis diagnosis and not for urinary retention. Next question. A patient is brought to the emergency department with symptoms of confusion, excessive salivation, diarrhea after exposure to organophosphate insecticide. Which of the following is the first line treatment for this patient? A. Neostigmine, B. Atropine, C. Pyridoxine, D. Physostigmine. Okay, yes, so a few of you answered C, but C is not the right answer. Yes, it is B, atropine. So basically, I get why some of you answered C. C could be the answer, but remember, pralidoxime is used to reactivate acetylcholine esterase, and it should be administered soon after exposure. But here, for immediate treatment of symptomatic relief, we use atropine because it is an anti-cholinergic agent which counteracts the cholinergic effects which are caused by organophosphate poisoning. So the best option would be to go for atropine. Whereas neostigmine and physostigmine are not appropriate because they would actually increase acetylcholine levels. Okay, someone's asking that the answer should still be C and it shouldn't be atropine because atropine is the antidote for phosphate poisoning. So the answer is, the question asked you, told you that the patient presents with symptoms. And in order to provide immediate symptomatic relief, you're supposed to administer atropine and not pralidoxime. Pralidoxime is given as soon as someone is exposed to this kind of poisoning. Is that clear? Now, let's move on to the next question. A patient presents with worsening muscle weakness after being treated with high doses of reversible acetylcholinesterase inhibitor for myasthenia gravis. Which condition should be considered as a possible cause for increased weakness? A. Cholinergic crisis. B. Myasthenia gravis exacerbation. C. Organophosphate poisoning. D. Acute respiratory distress syndrome. Yes, so someone answered A, and that is the correct answer, cholinergic crisis. Now, cholinergic crisis can occur when there is excessive dosing of reversible acetylcholinesterase inhibitors. And what happens is there is accumulation of acetylcholine at the neuromuscular junction, which causes muscle weakness. Now, this can be challenging to distinguish from exacerbation of myasthenia gravis, but whenever a patient presents with paradoxical, which is something which does not have a specific cause or pattern, and worsening of muscle strength, and because of increased doses of certain medication, it is cholinergic crisis. Is everything until now clear? Can we move to the next question? Okay. So the next question is, a 25-year-old female presents with Sjogren's syndrome and is prescribed a medication to relieve her symptoms of dry mouth. Which of the following cholinergic drugs would be most effective for this condition? A. Atropine, B. Pilocarpine, C. Methacholine, D. Carbachol. Okay. Someone answered B, and yes, you're right. It's pilocarpine. Why? Because pilocarpine belongs to which class of drugs? Is it indirect acting cholinergic or direct acting cholinergic? Yes. Excellent. It's direct acting cholinergic agonist which selectively acts on muscarinic receptors and makes it so it is basically used to treat dry mouth in conditions like Sjogren's syndrome. Whereas the other options we had, like atropine, it's an anticholinergic and it would worsen the condition. And methacholine is used for what testing? Methacholine is used for which testing specifically? Asthma, yes, bronchial reactivity. Perfect. And carbachol is less selective and rarely used for this indication. Now, yes, let's move on to the next question. A 65-year-old male with benign prostatic hyperplasia presents with worsening urinary retention after starting a new medication for motion sickness. Which of the following drugs is most likely causing this issue? Ipratropium, scopolamine, succinylcholine, tubercularine. Okay. Okay. Yes, you're right. Scopolamine. So the answer is B. Scopolamine belongs to antimuscarinic drugs and it can cause urinary retention by reducing the detrusor muscle contraction in bladder. And it can worsen the symptoms in patients with BPH. And it is used for motion sickness. So the main keyword in the question was motion sickness. As for antimuscarinic drugs, this is an easy way to remember the adverse effects, A, B, C, D, E, F. So A stands for anxiety or agitation, B for blurred vision, C for constipation, D for dry mouth, E for elevated temperature or hyperthermia, F for frequency of urination decreases, which is urinary retention. The next question. A 65-year-old male with Parkinson's disease presents with resting tremor, bradykinesia, and muscle rigidity. His symptoms are due to an imbalance between acetylcholine and dopamine levels in the basal ganglia with a predominance of cholinergic activity. Which medication would be most appropriate to help reduce the tremors by blocking muscarinic receptors in central nervous system? Options are levodopa, benztropine, pramipexole, carbidopa, bromocriptine. Okay. Few of you answered B and someone answered A. So the correct answer is B, benztropine. Now, benztropine is an antimuscarinic drug which helps reduce symptoms of Parkinson's disease by decreasing the activity of acetylcholine at muscarinic receptors in the brain. So what happens is there is the balance between acetylcholine and dopamine is restored. So the symptoms of like tremors and muscle rigidity are alleviated. An easy way to remember this is park your benz. So PARC stands for Parkinson's and BENZ for benztropine. Okay. Everything clear until now? Can we move on to the next question? Okay, great. So the next question is, a 45-year-old male undergoing surgical procedure requires muscle relaxation. The anesthesiologist administers neuromuscular blocking agent that is a competitive antagonist of nicotinic receptors. The patient later develops muscle weakness that is reversed by neostigmine. Which of the following drugs was administered? A. Succinylcholine, B. Tubercularine, C. Atropine, D. Rocuronium. Okay, yes. So someone answered B, and that is the correct answer, tubercularine. Now, the important thing here was to see the MOA or mechanism of action, which was mentioned, which is neuromuscular blocking, competitive neuromuscular blocking agent, and that acts as a nicotine receptor antagonist. So it was tubercularine, which prevents acetylcholine from binding to at the neuromuscular junction, and it results in muscle paralysis. And we can reverse the effects using neostigmine. That was also another keyword because neostigmine, it increases acetylcholine levels. So it would antagonize the effects of tubercularine. Now, The next question, an ophthalmologist is performing an eye exam, uses a tropical agent to dilate the patient's pupils. The drug blocks muscarinic receptors in the eye, causing mydriasis. Which of the following drugs is most likely used? Atropine, pilocarpine, tropicamide, phenylephrine. Okay, someone said B. No, sorry, B is not the right answer. Yes, it's C, tropicamide. Remember, for dilating pupils before eye examination, there are two drugs which are mentioned in your lectures, homatropine and tropicamide. Both have the word tropicamide. So you give them topically in the eyes. So tropicamide, homatropine, that is an easy way to remember. And they are short-acting muscarinic antagonist. So they are used to dilate the pupils and they paralyze the ciliary muscle. And why are they used as for diagnostic procedures when compared to atropine? That is because they have a very short duration of action. So they are good for diagnosis. Okay, so now let's move on to the next question. A 60-year-old male patient is being treated for gastric ulcer. The patient is given a medication that selectively reduces gastric acid secretion by blocking muscarinic receptors on parietal cells. Which of the following drugs would be appropriate in this case? A. Homatropine, pyrazipine, tropicamide, glycopyrrolate. Okay, yes, you're right. So the correct answer is pyrazipine. Now, pyrazipine, what it does, it selectively blocks the M1 receptors, okay? And it decreases gastric acid secretion from parietal, which helps in the treatment of peptic ulcers by reducing the acidic environment. And an easy way to remember is pyrates against acid. So pyrate, that stands for pyrazipine, and it helps you fight off the excess stomach acid. Okay, hope that's clear. Now let's move on to the next question. Which of the following adverse effects would warrant discontinuation of metronidazole therapy in a patient being treated for H. pylori infection? A. Mild nausea and vomiting. B. Metallic taste in the mouth. C. Peripheral neuropathy. D. Mild elevation in liver enzymes. Yes, perfect, you're right. So the answer is C. Peripheral neuropathy. Now, it It is one of the rare side effects for metronidazole, but as soon as you see someone experiencing this rare effect, you're supposed to stop the treatment. So it is very important to remember. And I know there are many side effects. So an easy way to remember all the side effects for metronidazole are never mess peacefully during alcohol quarrel. So N stands for nausea, vomiting, M for metallic taste, P peripheral neuritis, and this is the one which requires stopping treatment. D dizziness, vertigo, A alcohol disulfiram-like effects. So you should avoid alcohol if you're taking these medications. Remember that, that is important. And Q, QT interval prolongation. Now, let's move on to the next question. A patient is prescribed miltefosine for visceral leishmaniasis. Which contraindication should be considered before starting therapy? A. Renal impairment. B. Pregnancy. C. History of pancreatitis. D. QT interval prolongation. Yes, your answer is B, which is pregnancy. And why is it so? Because it has teratogenic effects. So it should be avoided during pregnancy, and women of childbearing age should use effective contraception if they are on this treatment for at least 5 months until after they stop taking the treatment. Now let's move on to the next question. A 45-year-old man with a history of leukemia is being treated for serious fungal infection. After starting treatment with a new antifungal medication, he develops fever, chills, and renal impairment. Which antifungal drug is most likely responsible for these adverse effects? Fluconazole, voriconazole, amphotericin B, caspofungin. The keywords here are the side effects. Yes, you're right. It's C, amphotericin B, because it causes an acute reaction as one of its adverse effects, which presents as chills, fever, nausea, vomiting, and also it causes nephrotoxicity, which was present in the patient in this case, and it is used for leishmaniasis. So all these keywords point towards the answer amphotericin B. Is that clear? Now, let's move on to the next question. Which of the following antifungal agents works by inhibiting the synthesis of ergosterol in the fungal cell membrane, thereby causing cell death? Amphotericin B, caspofungin, itraconazole, terbinafine. So the keyword here is the mechanism of action, synthesis of ergosterol in fungal cell membrane. Okay, someone answered D. Okay, yes. So C. C is the right answer. It is itraconazole. Basically, triazoles are the uh, drugs from antifungal medications which have the mechanism of action of inhibiting the synthesis of ergosterol in fungal cell membrane. So they disrupt the synthesis in fungal membranes and that leads to cell death. Whereas amphotericin B, because someone answered A, cannot be the right answer because it disrupts the cell membranes directly. And caspofungin, it has another mechanism of action. What's the mechanism of action of caspofungin?
Inhibit glucan synthesis.
Yes, perfect. So it inhibits beta-D-glucan synthesis. So that cannot be the answer. And terbinafine, it inhibits squalene epoxidase. Now let's move on to the next question. Which antifungal agent is considered the first-line treatment for invasive aspergillosis? A, nystatin, B, voriconazole, C, amphotericin B, D, griseofulvin. Okay, wow. Okay, few of you answered C and someone answered B. So the right answer is B, voriconazole. Because the keywords here were first-line treatment for aspergillosis. And the first-line treatment for invasive aspergillosis is voriconazole. Amphotericin B can be used, but specifically, if they mention first-line treatment, you can go with voriconazole as the option. Now let's move on to the next question. A patient receiving caspofungin for invasive candidiasis develops mild elevations in liver enzymes. Which of the following adverse effects should be monitored closely for this patient? Infusion site pain, renal function, blood glucose levels, or electrolyte imbalance? Okay, yes, you're right. So the answer is A, infusion site pain. That is because we administer echinocandins through IV, and that one of the adverse effects is injection site pain. And that is something we need to monitor for. As for renal function, this drug has favorable safety profile when it comes to renal function. So that can't be the answer. Okay, let's move on to the next question then. A patient presents with a pinworm infection and is prescribed parenteral palmoate. Which of the following best describes the mechanism of action of parenteral palmoate? A. Inhibits microtubule polymerization, leading to impaired glucose uptake in the parasite. B. Acts as a depolarizing neuromuscular blocker, causing paralysis of the worm. C. Binds to GABA receptors, enhancing inhibitory neurotransmission in the parasite. D. Inhibits DNA synthesis, leading to cell death of parasite. Yes, you guys are right. So the answer is B. Acts as a depolarizing neuromuscular blocker, causing paralysis of the worm. Now, an easy way to remember is parental paralyzes worms. So this might help you remember the mechanism of action. This. Next question. A 40-year-old male presents with symptoms of liver fluke infection and is diagnosed with fasciola hepatica. The physician prescribes a drug that should be taken on empty stomach to enhance its absorption. Which of the following drugs is most appropriate for treating this condition? Albendazole, mebendazole, triclabendazole, praziquantel. Yes, you guys are right. So the answer is C, triclabendazole. See, the main keyword in this question was fasciola hepatica. So because triclabendazole is the drug of choice for the treatment of fasciola hepatica, and it should be taken on empty stomach to enhance absorption. So remember that, that is something important, that it should be taken on empty stomach. Now, let's move on to the next question. A patient is being treated for hypertensive emergency and is given a medication intravenously to quickly reduce blood pressure. The drug also has beta blocking and alpha 1 blocking effects. Which drug is appropriate for this situation? Labetalol, timolol, metoprolol, atenolol. Yes, you're right. The answer is A, which is labetalol. And how did we get to the answer? The keywords were the mechanism of action, beta blocking as well as alpha 1 blocking. And it can be administered intravenously for rapid blood pressure control in hypertension or hypertensive emergencies. Whereas the other options, if we look at them, timolol is a non-selective beta blocker and it does not affect alpha 1 blockers. So that can't be the answer. Whereas metoprolol and atenolol are what kind of blockers? Which receptors do they block? Metoprolol and atenolol, beta 1. Excellent. But in the question, they also mentioned alpha 1. So that's why the answer was labetalol. Now, let's move on to the next question. A patient presents with hypertension and Raynaud's phenomenon. The patient requires alpha 1 selective antagonist to manage both conditions. Which drug is most appropriate choice? Phentolamine, prazosin, phenoxybenzamine, tamsulosin. Okay, that was quick. So everyone answered prazosin, and yes, that is the right answer. So prazosin selectively blocks alpha 1, which was a hint in or a keyword in the question itself, reducing blood pressure, and it helps elevate Raynaud's phenomenon. So remember, for Raynaud's phenomenon, and for sleep disruption and PTSD related nightmares, very important, it's prazosin. And to remember it easily, PPP. So prazosin for pressure, for phenomenon. The phenomenon is Raynaud's phenomenon. Okay. Now let's move on to the next. A patient with acute asthma exacerbation requires rapid bronchodilation. Which of the following medications is most appropriate considering the route of administration for quick action? A. Albuterol inhaler. B. Epinephrine oral tablet. C. Phenylephrine intravenous. D. Clonidine transdermal patch. Yes, it's A. It's very So remember, for asthma exacerbation A, you use albuterol inhaler, because also another point they mentioned the route of administration. So inhaler would be the best way to administer medication in such a case. And it is a beta-2 agonist. So for rapid bronchodilation during acute asthma attacks, it causes the bronchial smooth muscles to, it has a very direct effect on the bronchial smooth muscles and minimal systemic side effects. Is everything clear until now? Any questions? Okay, so let's move on to the next question. A patient is in cardiogenic shock and is administered a medication that increases heart rate and contractility without significantly affecting peripheral vascular resistance at low doses. What is most likely drug given? Dobutamine, dopamine at low dose, norepinephrine, or epinephrine? Yes, you guys are right. The answer is dobutamine A. Now, dobutamine stimulates which kind of receptors? B1. Perfect. So it stimulates B1 receptors to cause cardiac contractility or to increase cardiac contractility and heart rate, and it has minimal effects on peripheral vascular resistance. And an easy way to remember is dobutamine from dobutamine, and that helps you remember that it helps the heart beat stronger without causing vasoconstriction. The next question. A 30-year-old woman with a history of peptic ulcers is prescribed a medication to reduce gastric acid secretion. The drug is known to be a prostaglandin analog and is administered orally. After a few days, she experiences abdominal cramping and spotting. What is the most likely drug prescribed? Misoprostol, ranitidine, alprostadil, diphenhydramine. Yes, you guys are right. The answer is misoprostol. So misoprostol is a synthetic PGE1 analog, and it is used to decrease gastric acid secretion. And it increases mucus secretion, so that is helpful in the treatment of peptic ulcers. And it increases uterine contractions of the myometrium, which causes the abdominal pain and or cramping and spotting in this patient. An easy way to remember this is M. Misoprostol starts with M. It has an effect on mucus secretion. Now, the next question. A patient with severe allergic rhinitis and atopic dermatitis is started on a first-generation antihistamine for symptomatic relief. After a few doses, the patient experiences excessive drowsiness and dryness of mouth. Which property of the prescribed drug most likely accounts for these side effects? High specificity for H1 receptors, inability to cross the blood-brain barrier, antimuscarinic effects, short duration of action. Okay. So the correct answer is C. It is antimuscarinic effects, because first generation antihistamines like diphenhydramine, they can cross the blood-brain barrier. So inability to cross the blood-brain barrier can't be the correct option. And they cause sedation. And they have antimuscarinic or anticholinergic effects, which leads to dryness of mouth and other symptoms like urinary retention, blurred vision, etc. Next question. A patient is undergoing chemotherapy with Vinca alkaloids. Which phase of cell cycle is most affected by these drugs? G0, S phase, G2, M phase. Okay, yes. So the answer is D, M phase. Now, Vinca alkaloids, they specifically target the mitotic phase by binding to tubulin, and they prevent microtubule formulation, so they inhibit mitosis. And an easy way to remember this is visibly tall mountains, which stands for, the V stands for Vinca alkaloids, T stands for taxanes, and the mountains for M phase. And you need to remember the drugs and which phase of the cell cycle do they affect specifically. A few other ways to remember, ants are sneaky. So antimetabolites, the other A stands for antibiotics. Sneaky, the S stands for S phase. And cats grab all grapes. C for corticosteroids, grab for G1, A for antitumor, and the other G for G2. So hope these tricks help you remember them, inshallah. Now, let's move on to the next question. A 45-year-old patient undergoing chemotherapy with cyclophosphamide presents with hematuria and bladder pain. What is the primary reason for these symptoms? A. Myelosuppression, direct cytotoxic effect on bladder, toxic metabolite acrolein, D. Allergic reaction to drug. Yes, mashallah, y'all are very quick. The answer is C. Toxic metabolite acrolein. So cyclophosphamide is converted into acrolein, which is toxic to bladder epithelium, and that causes hemorrhagic cystitis. And how can we treat that? Mesna, perfect. Yes. So you give adequate hydration and mesna, which can help with this side effect. And a trick to remember this is CAB. So C stands for cyclophosphamide, A acrolein, and that has an effect on bladder, B. Now, so we have the last question, which is a 50-year-old man with chronic myeloid leukemia is started on imatinib. What is the drug's mechanism of action? Inhibition of topoisomerase, alkylating agent, tyrosine kinase inhibitor, antimetabolite. Yes, all of you are right. The answer is C, which is tyrosine kinase inhibitor. So imatinib selectively inhibits BCR-ABL tyrosine kinase, which is very important for the proliferation of CML cells. So the leukemic cells cannot proliferate. So that was it for today's practice questions. I tried to cover the most important or key concepts from all the lectures. If you have any questions, feel free to ask me through email or my number, and I'll be sending the slides, inshallah. And hopefully this session helped you recap everything. If you have any questions right now, you can ask those too. Also, the explanation for each question was the pics were taken from my tables, which I made last year, and also for the for few lectures, someone from your batch, Lama, she edited them, so those were taken from those edited tables. Okay. This is the QR code for feedback. You guys can scan it.